Hello my dear students, I'm Dr. Vaishaly Bharambe. I've been teaching anatomy for the last 25 years and I love it. This lecture is a part of my chromosomal abnormality series. Question 1. What is chromosomal abnormality? Students, when there is a change in the number, in the structure or in the arrangement of a chromosome, you call it a chromosomal abnormality. This can be in the structure or it can be in the number. If the structure is altered, for example, a bit is fallen off, a bit has got attached here and there, or it has changed its position, you call it a structural chromosomal abnormality. Lecture about this has been uploaded. There are 2 lectures uploaded, the link for which is given in the description section. I encourage you to go and take a look at those lectures. Numerical is when the number is either increased or decreased. Out of total 46 chromosomes, suppose you have 1 more, or you have 2 more, or you have 1 less, then the number is altered. You call that as a numerical chromosomal abnormality. For example, I'm sure you know that. For example, trisomy 21, monosomy X. A lecture on both these abnormalities also has been uploaded. Okay, again in the description section you will find the link for both the lectures. Today we are talking about the Klinefelter syndrome. Also, I'm sure all of you are familiar with this because nowadays it's covered in your school years. But what is expected from you once you are in medicine? How much knowledge is expected? Is it the same as what was taught to you in your school years? No, students. You are expected to know the genetics behind it. The external characteristics, I'm sure you can tell me now. But what is the genetics behind Klinefelter syndrome is what we need to learn today. Okay, so let's dive in. Klinefelter syndrome, a numerical chromosomal abnormality, a sex chromosomal abnormality. It's not just a number, it's a sex chromosomal abnormality. Right. So again, madam, you brought horses and chimpanzees in your lecture. How do you manage to get animals in your lectures all the time? I managed to get them because I love them. I love animals. I believe they are a pure form of living. They live by their own rules. They don't break their rules. There is a lot we can learn from them. Anyway, I could just go on and take a lecture on animals, but we'll not go there. Students, every animal has their own set of chromosomes. Horses 64, chimpanzees 48, dogs 78. But they too have got only 2 sex chromosomes, one X and one Y. And this X and Y determines their gender, just like human beings. Okay, so we too have 46 chromosomes, which means we've got a haploid number of 23. We've got 22 autosomes, 2 sex chromosomes. If it is XY, then we call it a male. If it is XX, we call it a female. Okay, I'm sure you knew all this. But then, what is sex chromosomal disorder? When there is more or less of the expected number of sex chromosomes, you call it a sex chromosomal disorder. For example, Klinefelter's 47XXY, Turner's 45X, 1 missing, trisomy X, triple X, 3 X's, XYY males, and so on. The list is there, so many of them. Okay, so today is about Klinefelter's syndrome. Right. Klinefelter syndrome, an extra X. Right. This syndrome was first described in 1942 by Harry Klinefelter. Did he know the chromosomal abnormality? No, he didn't. In fact, there's a very interesting anecdote about it. I'll come to that later. It was in 1959 that they found out that, he has 1 extra X chromosome. Just like the timeline is exactly the same. The same thing happened for Turner's and the same thing happened for Downs. It was in 1959 that all these abnormalities were detected chromosomic. The history goes that there was a male who was found to be having a bar body. And then they began to think that males actually don't have bar bodies. How come he has a bar body? And then the Klinefelter syndrome was kind of discovered. Okay. The incidence of these boys is about 1 in 1,000 babies, and the chromosomal findings are 47XXY in almost 30 to 90% of the cases. In 10% it is mosaicism. How many of you know what is mosaicism? Yes. Mosaicism is a condition wherein in the same person there are two separate cell lines. One cell line, for example, is 46XY, normal male. But he's got some set of cells which are 47XXY. Okay? Or you may have, a person has some cells which are 45X, some cells which are 46XY, and some cells which are 47XXY. Okay? All these are mosaicisms. People have this. Or 46XY, 48XXXXY, and so on. I'm not going to read all this. Okay? So this is all these come under the gamut of Klinefelter's syndrome. 65% of the error is maternal, 35% of the error is paternal. Okay, ma'am, mother is making a mistake or father is making a mistake. Is that what it's all about, somebody's mistake? No, students. Let's try to understand what I mean by 65% error is maternal. Let's try to understand this. For that, I want to take you to normal cell division. This is a normal cell which is dividing by meiosis to produce two daughter cells, meiosis 1. Meiosis 2, the same daughter cell now splits the chromatids and the daughter cells formed have one chromatid each of that pair. Thus, normal haploid gametes are produced. We know that, correct? Now, what happens if this is a male person? Look at that, I've written XY. So, this is a male going into gametogenesis. Okay? During gametogenesis, in meiosis 1, the X and Y are rather attached to each other. I will not go to daughter cell. X and Y, we are a pair, hum saath saath hai, we'll go together. So, one daughter cell has both X and Y. Okay? Now, when this goes into meiosis 2, okay, then they will split. So, the daughter cell will have, the final gamete will have both X and Y chromatids. See? Each of the gametes is already having one X and one Y chromatid. Now, when a normal gamete from the mother comes in and fuses, the progeny will have one XY from the father and one X from the mother. So, what is the total number? 47XXY. This is how Klinefelters are produced if there is a non-disjunction in the paternal meiosis. So, the X will be written as XP, meaning paternal X chromosome. This is what happens to the leftover cell. Let's talk about if non-disjunction happens in the mother. Okay. So, same thing. This is the cell which is going into meiosis. Two X chromosomes are present in it. The two X's refuse to separate. Therefore, the daughter cell has two X chromosomes. Now, when it goes into meiosis 2, all the gametes already have two X chromatids. Already have got two X chromatids. Now, it fuses with a Y coming from the father. What happens? Progeny is having two X from the mother and one Y from the father. XXY, 47XXY. Okay, in this case, what are the X coming from? The X's are maternal. So, when we said that 65% error is maternal, it means that this kind of abnormality is occurring in 65% of the cases. And in 35% of the cases, it is paternal non-disjunction which is resulting in Klinefelter syndrome. Are you understanding? Now, question is, madam, in the beginning you showed us so many X's, XXXXY. How did that happen? Okay, let's take a look. It's like mathematics. Students, I come from a family where all of us just love maths. So this is fun for me. I hope it's fun for you too. Right. So let's talk about this case where this is the father going into meiosis, XY. We saw non-disjunction in meiosis 1. One daughter cell is having both X and Y. This is old news, we know it, isn't it? Now let's talk about meiosis 2, where again it says non-disjunction. The two chromatids they refuse to separate. So both chromatids of X and both chromatids of Y go to the same daughter cell. One daughter cell is having two X's and two Y's. Can you see that here? Okay. Now let's add a X coming from the mother, normal gamete. So 1X from the mother, 2X from the father, 2Y from the father. How many sex chromosomes? 5. How will you write it? 49X, XX, YY. This is how such abnormalities get produced. Okay? I can just mix this around and produce any number of abnormalities you wish, but this is the basic concept. Right. So what is the effect of this extra X chromosome? How does it matter? It should strike you. If this question has not stuck you, it should have struck you. Why? Because we've discussed what is called Lyon hypothesis. Remember? When we said that 1X gets inactivated. If 1X gets inactivated, then why do we call this guy as a Klinefelter syndrome? His 1X is anyway not active. So XY of a normal male should be equal to XY of Klinefelter. But that is not true, because if you recall, we had a discussion that X gets inactivated on 15th to 16th day of intrauterine life. So till 15th to 16th day, the X is active, laying down the foundation for some female development, which is what happens in Klinefelters. Also, there is something called pseudo-autosomal region. Okay, if this is remaining active, then the triploid genes could explain Klinefelter syndrome. You understand? So Klinefelter's XXY is not equal to XY. Right. So what are the symptoms then that develop because of the extra X? Let's take a look. Here you are on familiar territory. You've been taught this in your school years. Oh, ma'am, he looks very tall. Yes, he is tall. He is a phenotypically male person who is tall and almost unicoid. It's described as unicoid. I'm not comfortable with this term. Okay, but he's a very tall person. He's got very long lower limbs. He's got weak bones because he's got higher amount of estrogen. He's got decreased facial hair, body hair. See, females have lesser body hair, which is what is happening in this case. Less muscular compared to other men. Increased belly fat. Okay. Secondary sexual characteristics are poorly developed. He doesn't exactly look like a male. Somewhere in between. Again, observe that till now I kept his genital region covered. I want to make my point very clear. These are people who are having a problem. That's why they have come to you with complete trust. It's important that not only we treat the patient, we also treat their mind, which is where we need to maintain their dignity. Expose the patient only when necessary. The rest of the time, keep the patient covered. If you're taking a photograph, then ensure that the identity of the patient is not released to the public. Here, if you have the time, I have a small story to tell. It's not a great story, but it's something you need to understand. When I was a student, I just finished my medicine. I was working in a hospital. It was in a smallish village. And suddenly there was a lot of running around and everybody was saying, X person has come as a road traffic accident. This X person was a person of prominence in that village. He and his wife had gotten into an accident and they were brought to the hospital in unconscious state. Their 3 children, however, were quite okay. And then suddenly I saw that after he was admitted, there was a lot of hush-push and, a lot of talking among the people. So I said, what happened? What are you all discussing? Then there were sisters who were giggling and there were ward boys who were looking here and there. I said, what the hell is going on? Then I was told that this person was having some kind of genital abnormality, which kind of negated his ability to have progeny. Whereas he already had 3 children. So there was immense gossip about this man of prominence in that village, where he was now denied his dignity. As a patient, he has a right to secrecy about whatever he reveals. But this was completely lost on all those people. And I kept telling them, stop talking about it. I'm sure he's taken treatment. and he's got his progeny. It's not up to us to judge them and try and find out how he's got his children. He has got them. He's come as a patient. He has every right to be treated. So remember, the dignity of that patient is extremely important. And you must be empathetic and think, would you like to be in his shoes? If you will not want to be in his shoes, then you must treat him the way you would like yourself to be treated in the similar circumstances. Am I making myself clear to all of you? Okay? Alright. So we keep his genital region covered. We expose it only when we want to discuss it. Okay? Right. So we see that he's got a small penis. He's got a small testis which has already undergone hyalinization. So low sperm count or almost no sperm count. He is likely to be sterile. Of course, if he's a mosaic, there could be variations in this. He's got a low sex drive. He's got gynecomastia. Okay. A verbal IQ of 10 to 20 points less, but otherwise rare for them to show mental retardation. However, in cases which have more number of X's, like 48XXXY, 49XXXY, these are cases with quite severe mental retardation. Now I want to come to my pet way of teaching. Students, our memory has got limitations, but our mind has got a place for images. Use images to remember. So here you are seeing an image of this Klinefelter's patient. Look at him. You know the answer right there. Okay, so what do we know about him? Let's revise. So he is a person who is of tall stature. He's got little or no chest hair. He's tall. He's got some belly fat. Remember, he's having some features similar to females. He's got gynecomastia. He's got a small testis, small penis. He's got poor secondary sexual characteristic development for a male. He's got somewhat feminine physique, and he may have a slightly reduced IQ. A single image can get you so much information. Don't bother to mug. Try to create an image and use that image to move forward in your education. With time, the rest of it comes in. Okay? Right. Students, if you're enjoying this lecture, do please like and subscribe to my channel. I request all of you to put in comments once in a while so that I'll know whether you're really liking it or not. Right. Now see, these patients have an extra X. Does it bring its own problems? Yes, it does. They are more likely to suffer from diabetes mellitus, thyroid disorders, peptic ulcers, leg ulcers, pulmonary emphysema, hemorrhoids. Acute or chronic leukemias hit Klinefelters more often than others. Cancer, CA breast surprisingly is more common in Klinefelters. Okay? What are the risk factors that lead to Klinefelters? One of the biggest risk factors is always going to be maternal age. Like I told you, advancing maternal age can lead to Turners, can lead to Klinefelters, can lead to Downs. So, ideally you should have your babies early. It's difficult in today's world where all women are also working. But it's time we make time to have our babies, because otherwise Klinefelters, Turners and Downs are always a part of our life. Right. When is he detected as Klinefelter? See, he is born a male. He looks like a male. So it's likely that he doesn't get detected at all. Then he goes into puberty. He looks like a slightly softish male, And then he hits puberty and the parents expect him to develop all secondary sexual characteristics, which doesn't happen. And that's when he comes to the hospital and says what is going on. Otherwise, then what will you do? You will do a bar body test. There you have your answer. Or you can do a karyotyping. You can aspirate blood and do a karyotyping. You can, of course, do a hormonal profile, testosterone levels, FSH, LH levels. That will give you an answer. What can you do for him? He's got a chromosomal abnormality. What will you do? Detect early, treat early. Okay? So what you do what is called as hormone replacement therapy, HRT. You begin to give him testosterone. Once he hits puberty and you give testosterone, he'll develop all the secondary sexual characteristics. Then you maintain that therapy, because they have to be maintained also. Okay? And then it also prevents him from getting osteoporosis. For infertility, you do what is called ICSI, intracytoplasmic sperm injection. So you're just injecting the sperm into the egg directly into the secondary oocyte. So fertilization will take place and he'll definitely beget progeny. Always give him emotional, behavioral and psychological support. See, his is not a common condition. There will be times when he will doubt himself. There will be times when he will feel lonely, challenged, and sometimes ostracized. So it's up to us to emotionally support, psychologically support these individuals. Also, he has to be all the time in touch with healthcare professionals, endocrinologists, psychologists, and genetic counselors. Why genetic counselors, students? Because he is going to pass it on to his progeny. So there is always that chance, isn't it? So that has to be considered, that has to be discussed with him before his decision to become parent. Right. So with this we complete Klinefelter syndrome. Students, again this is a very common short note. How will you attempt it? Right. So first you will talk about what is a chromosomal abnormality. Then you will talk about structural, numerical. See, bring your examiner into the game. Don't just dump information on them. So then one of the numerical chromosomal abnormalities is Klinefelter's. Then you begin to talk about what are the basic genotypes, how there is a 47XXY, how there are so many different mosaics that can also present as Klinefelter's, and so on. Then explain how non-disjunctions lead to Klinefelter's. I have explained it to you. Nothing should stop you from explaining it to your examiner. Correct. Then you come to when was it first discovered? When was it first described? When was the chromosomal abnormality understood? See, all these syndromes were first described as syndromes. It was in 1959 that the chromosomal abnormality got detected. Otherwise, as syndromes, they were being described. Then you talk about clinical features. How will you talk about it? You will close your eyes, you will imagine that male, and then you will just read off the image in your mind. Okay? Then when is the condition detected? You think about it. Don't just randomly say X time. You think about it. The child can be detected as male, talked about as male, brought up as male. And then at puberty, he will have his own challenges. And then that's when likely he will come to the doctor. How is the condition investigated? How is the condition treated? Okay? And with that, you will complete your answer. Students, if you enjoyed this lecture, please like and subscribe to the channel. I would love it if you shared your thoughts in the comment section. I really need to know whether all these lectures that I am painstakingly creating are really helping you. The aim is to ensure that education of a certain standard is available to every medical student in our country and worldwide. Okay, that's my effort. But unless you give me some feedback, I will not know whether I am successful in giving that education to all of you. So this is a humble request from me. Please share your comments. Let me know whether I am really helping you or not. Right. So an MCQ. Let's see if you really understood something. All the following karyotypes are associated with Klinefelter syndrome except 47XXY, yes. 46XY, 47XXY, mosaic, yes. 47XXY, 48XXYY, yes. 47XXX, no, that is triple X, that is trisomy X, it's not Klinefelter's, isn't it? So that's how common sense, understanding of genetics lead you to correct options in MCQs. Okay. So with this, we finish this wonderful lecture on the extra X 47XXY. I enjoyed taking this class. I also enjoyed, I'll say I felt the responsibility of putting across ethics of treating these patients to you. I hope you take it in the right spirit. Thank you, students. See you across the screen in some other video. Bye.